Well, so good evening, friends, and at the outset, let me thank Dr. Chauhan and all of you for being here. And if you look at the, so this is, somebody said that you are ending the year and beginning the year also for the PFI. And this is a good PFI. This is not the PFI which we are scared of. So I said that आगाज और अंजाम दोनों हम ही देते हैं. So if we can have slides. So if you look at the today's topic, which is really looking at what we call residual risk in cardiovascular atherosclerotic cardiovascular disease. So we know that statins have really done wonders. There are a lot of anti-statin groups, but we know that there is nothing better than statins to decrease the bad cholesterol levels and you can decrease the risk of cardiovascular adverse outcomes significantly. So, but we know that statins alone cannot really do the job. So we need to do something more than that. We have fenofibrate, but if you look at the data, fenofibrate has not really translated, though it will decrease the triglyceride and the cholesterol to some extent, but it does not translate into decreasing the adverse cardiovascular event. We also had the molecule ezetimibe. We did not have much data which supports ezetimibe for the decreased COVID trial. Only showed that if you give it in combination with the statins, probably the adverse cardiovascular event would come down significantly. But that's now we have got, as Dr. Chauhan also said, that PCSK9 inhibitor, and we have been using it quite extensively in patients who can afford it and who have the indication. So those who have got familial hypercholesterolemia, those who have got cardiovascular disease at a very young age, in these cases we really use this molecule and have got good outcomes. We can decrease the cardiovascular event rate, but we were looking for something which is non-injectable. So the combination of Rosuvastatin and Bempedoic acid was really a good thing to happen, because we had some combination of statin and ezetimibe. What this combination brings to us is the drug complements each other mechanism of action, so they are complementary or synergistic in action. There is an influence on cholesterol pathway at different levels to optimize the LDL control. There is a significant or robust LDL cholesterol control in combination of Rosuvastatin and Bempedoic acid. So you are giving oral most powerful agent, Rosuvastatin and Bempedoic acid, and that is something which is matching the dosing profile, making it more easier and simpler, because you don't have to really go and get injected. And we know our country that even in diabetes, people who practice diabetes, they know that how difficult it is to, Dr. Monashis, Sahu will also vouch for that it is very difficult for transferring our patient from oral tablets to injectable insulin. So this is similar to that people don't really like to have injectable molecules. So Bempedoic acid is something which is indicated in adults with primary hypercholesterolemia, heterozygous familial and non-familial or mixed dyslipidemia as an adjunct to the dietary modification. And at the outset, Dr. Chauhan also said there are a lot of patients who would really, they would attribute that they don't tolerate statin, they have muscle cramps and other problems. So these are molecules which is basically for people who do not tolerate statins, or where the goals with the statin alone is not achieved, or you cannot go to maximum possible dose with this molecule. So what it does is that it also acts with the same pathway for cholesterol synthesis like that statin, but target a different enzyme. So this is the place where the Bempedoic acid would be working. And so obviously this is also targeting the same place, that is the liver enzyme. And what it does is that it inhibits the ATP citrate lyase enzyme. So ACL enzyme is inhibited and upregulates the hepatic LDL receptors. which is ultimately responsible for removing the LDL particle. And we know that LDL is the bad cholesterol, and with that, the outcomes will be, if you decrease that, the outcomes will be good. So, if you see the clinical data, there is a large data from clear trial, 17,000 patients were included in that, clear harmony, clear serenity, clear wisdom trial, clear tranquility trial, and all of them did really show that it is a molecule which will decrease the LDL cholesterol. And if you see the clear harmony data, that shows that within 2 weeks of phase 3 randomized double-blind placebo-controlled trial, that really showed that the primary endpoint was the incidence of adverse events and changes in safety laboratory variables, and also the percentage change in LDL cholesterol from baseline for 12 weeks, and percentage change in the level of LDL, total cholesterol, FOB, and HSCRP from baseline to 12 weeks. So you know that all these molecules and the parameters, we see that HSCRP and all they are predictors of adverse cardiovascular outcomes. So on top of statin, clear harmony trial did show that on the background of statin, the incidence of overall serious adverse events did not differ substantially between the two groups. So they see the evidence from Bempedoic acid on the safety profile. So this was really well tolerated in all these groups, and also treatment with Bempedoic acid resulted in greater lowering of LDL cholesterol level than was observed in the placebo group. So definitely this is a molecule which is much more stronger than ezetimibe. We know that people who do not tolerate statin, if you put them on Bempedoic, ezetimibe, the decrease in the LDL cholesterol and total cholesterol is not as significant, but in Bempedoic acid there is a significant decrease in the LDL cholesterol and total cholesterol. And this 52-week trial data with the Bempedoic acid added to maximally tolerated statin therapy. So a lot of patients who become symptomatic muscle cramps and all on 40 milligrams of Rosuvastatin or 80 milligrams of Rosuvastatin, decrease the dose and add Bempedoic acid, and then they tolerate it better, and they will have a better lipid profile, the LDL cholesterol dose to acceptable level. Clear wisdom trial also did show this similar thing, 52 weeks of the 53.3% used high intensity statin therapy, that is 80 milligrams Rosuvastatin and 40 milligrams Rosuvastatin. So there also the patient in the background of the statin therapy where given Bempedoic acid, the reduction in LDL cholesterol observed at week 12 were maintained 2 weeks to 52 in Bempedoic acid, meaning thereby that not only you get a reduction in the LDL cholesterol, that was 17% and reduction at 12 weeks, but also the maintenance is also there, and there was significant reduction at week 12 with Bempedoic acid versus placebo when observed with the level of non-LDL cholesterol, total cholesterol, FOB and HSCRP. So remember, in Indian population, FOB and HSCRP are also a very, very strong predictor of adverse cardiovascular outcomes. So in this trial, the conclusion was that among patients at high risk of cardiovascular disease receiving maximally tolerated statin, addition of Bempedoic acid compared with placebo resulted in significant lowering of LDL cholesterol over 2 weeks. There was one criticism that probably this lowering of LDL cholesterol may not translate into reduction in cardiovascular outcomes. But a week back, there was a data which showed that with the Bempedoic acid, you get reduction in cardiovascular events. So that was something which was plus point compared to the ezetimibe and also fenofibrate. Fenofibrate in none of the trials did show to decrease the adverse cardiovascular outcome despite lowering the triglycerides significantly. So all these clear trial and serenity trial, they did show that there was a significant reduction in LDL cholesterol, secondary lipids, and the biomarkers were observed at 12 weeks. So even for 3 months, you see significant reduction in. So if you see non-HDL cholesterol, FOB, so this is you will be knowing that in Indian population, lipoprotein B is a very, very strong predictor of the genetic marker. It doesn't go down with statins, but it will go down significantly with PCSK9 inhibitor and Bempedoic acid. And with that, there is a significant reduction not only in LDL cholesterol but also the F4 B HSCRP. So similar to what the statin would do, you have the reduction in HSCRP also, and of course the LDL cholesterol. So the evidence does show that the bempedoic acid offers a safe and effective oral therapeutic option for lipid-lowering patients who cannot tolerate statins. So the clear tranquility data also shows the similar thing, that there is a significant reduction if you see from the baseline significant in LDL cholesterol to bempedoic acid when you compare with the placebo, and they were observed at first post baseline 24 weeks and were maintained throughout up to 14 weeks. So there is no, what we call tachyphylaxis. The reduction will continue. This significant reduction in LDL cholesterol secondary to lipid and biomarkers were observed at 12 weeks also. So we know that these agents which decrease the event rate. So the problem with the ezetimibe was that you did not get reduction in HSCRP and the apolipoprotein B, but with this bempedoic acid, there is a reduction in both these markers, and probably that would be the reason why the bempedoic acid is something which is having a similar effect what we get with the statin. So there is a synergistic action between the two. So the conclusion of this, data was that bempedoic acid may provide an oral therapeutic option complementary to ezetimibe in statin intolerant patients who require additional LDL lowering. As we said that we had resorted to PCSK9 inhibitor, but that is still injectable, so you can't really rely on that. A lot of patients would not really accept that. So if you look at the atherosclerotic cardiovascular risk profile, so patients who are on high dose of statins, and if they are not meeting the target, then we resort to injectable PCSK9 inhibitor. But now we have got data and the molecule available right here. So what we does is that if you look at the data from the analysis of phase 3 trial, clinical trial of bempedoic acid versus placebo, the decreases are of sufficient magnitude to provide meaningful changes in cardiovascular risk profile. So we know that if we decrease the LDL cholesterol significantly, the overall cardiovascular risk profile will become much more favorable. Bempedoic acid also added to maximally tolerated statins, which doesn't mean that you need to go to maximum dose of statin, but maximally tolerated. So somebody is having symptoms of liver enzyme going high or the myopathy and all, then in those cases of those who have got already compromised status of the liver function and all, in those situations we can go with the bempedoic acid. And the data also shows that clear outcomes will determine whether the bempedoic acid 180 mg daily dose reduces the incidence of adverse cardiovascular event in high vascular risk patients and big documented statin intolerance. And as I said, the data which has come out has shown that it has got similar outcomes. So though it has not come in the guideline, but definitely it is going to be inculcated in that because it has shown really good outcome in reducing the cardiovascular outcomes. You remember there are a lot of trials we had AIM high trial with niacin which increased the HDL, that did not translate into reduction of cardiovascular outcomes. So adverse outcomes, but with this molecule, the data is more showing that if you use this molecule and decrease the LDL cholesterol, decrease the apolipoprotein B, then the adverse outcomes and the event will go down significantly, and that is what you want in this patient, in our patient as well. So if you see the evidence from clinical trial, statins plus the bempedoic acid versus statin alone, and you clearly see that these are the smaller trials, but they clearly show that bempedoic acid with atorvastatin or with any statin, the overall reduction in the event rates and the total LDL cholesterol is significantly lesser. It means that, and then because if you are giving it does not add on the adverse outcomes also. So if you see the adverse reaction of bempedoic acid, anemia was at 1 million, gout, hyperlipidemia, the liver enzyme going high, pain, and the increase in creatinine, urea level, and GFR going down. But if you see combination of the bempedoic acid with the statins, then you can give it in doses where they are not the highest possible dose, but they will compensate for each other and overall outcome will be much better. So the patient safety profile would be much better. So bempedoic acid has got a unique and novel mechanism of action, that is ACL inhibitor, and it targets the underlying pathophysiology, removing the LDL particles from the circulation, which results in lowering the LDL cholesterol, and it is a prodrug. So what it does is that its enzymatic activation occurs in liver through an enzyme called ACSPL1, and this enzyme is not present in the adipose tissue or muscle tissue, which may explain how low muscle complaints with the bempedoic acid. In fact, it is one of the #1 prescription for indication for bempedoic acid is that those patients who come with muscle pain and all and are not tolerating statin, this is the drug which we give. Novel non-statin drug approved in 20 years, and addition of bempedoic acid therapy demonstrates up to 28% reduction in LDL cholesterol with once a day doses. Thus, 180 milligram bempedoic acid is a promising drug for patients requiring additional lipid loading, and this is now a lot of patients have come back to us where we have shifted from PCSK9 inhibitor to bempedoic acid plus the rosuvastatin combination, and they have got really good outcome and the 28% reduction, further reduction on top of what you get from statin. It's a really very robust reduction, and it also fills the same gap as Kumar and PCSK9 inhibitor. So in fact, the need for PCSK9 inhibitor has really gone down when the combination of bempedoic acid and rosuvastatin you are giving. And it's an oral drug, so the advantage is over PCSK9 inhibitor is definitely there for the patient, and it has been well tolerated. So if you look at the trials, the tolerance with this molecule is really good, and in my practice I have not had to stop or remove the patient off this medicine, and the fixed combination of rosuvastatin plus bempedoic acid 180 milligram and rosuvastatin 40 milligram is the best recipe to reduce the LDL cholesterol to lowest possible range, so that the patient will reduce the benefit of decreasing LDL cholesterol, and also the addition of bempedoic acid will decrease the lipoprotein and HSCRP. So rosuvastatin is also molecule to decrease the HSCRP. So with that, they would decrease the overall adverse cardiovascular outcome. And I think, to my mind, in acute coronary syndrome, where the HSCRP is a predictor of adverse outcome, is again a great molecule. So I think we need to have more data with this combination, but definitely this is something which is going to be very, very promising in the next few years. So thank you very much for your time and attention.
We'll have the question answered.
Just 50 questions, Dr. Viveka. So, friends, that was a fascinating talk on diabetes with bempedoic acid, and if you could add erythemide as well. Journal of Lipidology just a few months back said 90% of the people could achieve the targeted LDL levels. What do you say, sir?
Yes, I think that is what we were looking at. If you look at the LDL targets, we were not achieving it more than 1/4 of the patients. But when you combine the maximum tolerable dose of statins plus bempedoic acid and erythemide, the outcomes will reach up to 90%. So imagine how much decrease in adverse cardiovascular event rate would be there, because it's a direct translation into reduction in LDL and adverse cardiovascular event rate.
So, Dr. Viveka, the statin pleiotrophy, we are so aware of that. So, any similar effects with BA?
Yes, to be honest, we never had any molecule which had pleiotropy to the extent which the statins had, and that is why the acid failed and we had also the erythemide which did not come to the expectation till the COVID trial come. So now, with this bempedoic acid, we have reduction in HSCRP, we have reduction in hemolipoprotein B, and these are very, very important to our population. So I would say that yes, though we need to have more data, it's nowhere as much data with the Bempedoic acid as we have with statin, but definitely this is much more promising than any other molecule except statin till now.
So talking about data, Dr. Viveka, so BMG published meta-analysis of 4,000 patients, 6 RCTs, and said there were no significant effects on various CV outcomes seen as yet. But a larger clear outcome trial is expected somewhere in the first quarter of next year, which will probably tell us about 14,000 patients across 32 countries. I wonder if you were part of that?
Yeah, so I think if you look at the enrollment data, that is 17,000 patients included in clear trial, and there the event rates and the decreasing as well as the cardiovascular event rates are significantly lesser compared to placebo. So probably and that is far more Rosuvastatin and the Bempedoic acid would be the ideal drug combination for our Indian patients, where the apolipoprotein will go down, we will have decrease in LDL cholesterol, and also we will have decrease in HSCRP, so probably the acute cardiac syndromes can be contained with this combination.
Finally, Dr. Viveka, hyperuricemia and increased creatinine probably seen with these patients, so it's prudent for us to probably assess uric acid levels and creatinine before we start the patient on bempedoic acid and probably monitor them regularly.
Absolutely. So I think we know that this is something which is kind of expected side effects, but it's not, the incidence is not really very high. It's not more than 5-6%. So probably you're right that we need to have a baseline, but fortunately these two things can be contained with the other molecules, so we can add the elafibranor and control them.
Wonderful. Dr. Mangla has a question.
How does it cause anemia? So does it, drugs like lenalidomide, they cause very severe anemia. So how does it cause anemia and to what extent the hemoglobin goes down? And how frequently should you monitor hemoglobin? Because somebody has a hemoglobin of say 11, 10, if it goes down further to 8, 7, it's a cause of concern, and do you have to withdraw the drug if it causes anemia?
So it's something where the anemia is not really very common and it doesn't cause severe anemia. So what it does is that there is a mild anemia which is though statistically significant, but we really, if you look at the incidence of stopping, need for stopping the drug for the sake of anemia, that has been really very minuscule. So I don't think that's a...
Is it at the level of marrow or otherwise?
No, so it's not at the level of marrow, because the marrow suppression is not the described side effect of this molecule.
Sir, Dr. Viveka sir, wonderful presentation as always sir. And I heard your presentation on Vipatha also. And lately what I have seen is ever since Bempedoic acid has been launched, the Vipatha people have started saying that we are promoting this PCSK inhibitors only in ACS. The chronic indication has gone away. So, I mean, thanks to Bempedoic acid. So, my question is, instead of Vipatha, can we consider this as the primary treatment even in ACS?
Yeah, so that's what I said, that any molecule which decreases the HSCRP, any molecule which decreases the apolipoprotein, so we can consider them. Last week we had preliminary data from clear trials and the 17,000 patient studies, and that showed that the atherosclerotic cardiovascular event rates, not only the risk, relative risk, but total event rates have come down significantly. So you are right that probably this is something where the future lies for the oral therapy. And the reason why, till now, PCSK9 inhibitor has very, very strong data to reduce the second myeloid infarction in younger patients. So that is why it is propagated more strongly in that subgroup. But if the LDL is the culprit, then probably, now you would be aware that the new target is less than 50. So if the new target of less than 50 is achieved, with this molecule come in combination with Rosuvastatin, 40 milligrams, then probably the molecule to look forward. And you are right that in ACS also this is what the combination would work.
Sir, regarding statins, we always say once on statin, always on statin. What about bempedoic acid? Once on bempedoic acid, always on bempedoic acid?
Yes, I think we need to have more data of pleiotropic effect. So, bempedoic acid would be, something where your targets are not reached. Then you use it on the target reaches, then just continue the statin and then stop the bempedoic acid. So, I would say that this is something which is for your, target achievable molecule.
Sir, we have two legends here, Dr. Viveka and Dr. Monashis Sahu. One of the criticisms of statins have been that they cause impaired glucose tolerance. And it is usually in people who already are vulnerable to impaired glucose tolerance anyway. What about bempedoic acid? When you combine the two, is there elevated risk of IgD?
No, so I think it remains the same as with the statin therapy alone. So it doesn't really add on that, adverse event, but I think we'd like to hear from Dr. Sahu as well.
Yeah, after his presentation. More questions? Yes, Dr. Kala sir.
Sir, I have a feeling that Dr. Viveka will not have cheers with me in the end of the year. Probably he is living because he is winding up. Sir, मुझे आपका वो याद आ गया कि अंजाम से आगाज से अंजाम तक मैं ही मैं हूँ, दूसरा कोई नहीं. We call it carrying through the innings. You are the champion, sir. I wish the next year also you become the same. Sir, my questions are not many. I was distracted by some media coverage about checking your heart by X-ray chest, checking your heart by eye examination, say foretelling or say predicting your risk scores. How good are they? I'm writing from the say field probably. So what is your comment? Can we predict our risk of ACFCD, say about cardiac involvement of atherosclerosis, cardiovascular disease by examination of X-ray and examination of eyes?
Yeah, so I think it's a very good question. So there is a lot of data which has gone in this direction that, one of the problems and biggest criticism of acute myocardial infarction and acute coronary syndrome is that unless it happens, you can't predict it. And 65% of the acute heart attacks and acute coronary syndromes, they are the first event. It's not that the chronic coronary syndrome will happen and then acute coronary syndrome. So people are asymptomatic till they get an acute heart attack. You are right that a lot of investment has gone in that direction. So a lot of artificial intelligence company has come up with the idea, and there is a doctor, so Apple company has also come with it. For the arrhythmias also, there is an Israeli company which has come up with measurement of 6 parameters, which will be, there is an algorithm which will be saying that there is an increased likelihood of acute coronary syndrome in particular. So obviously they should evaluate it for. But you'll be glad to know there is an Indian doctor, Dr. Sahu, who has devised a wearable watch where the drop, highly sensitive drop, would be measured without any invasive thing. So it's just a wrist watch which will say that the HSCRP is going to rise, and you can predict that the patient is going to have an acute coronary syndrome and acute heart attack. So that will be the game changer. FDA is likely to approve it by March next year, and this is going to be presented. This paper is going to be presented in ACC March session in Louisiana and US. So probably that is something which is, we are very tight that this, what we call gap in knowledge in predicting the acute heart attack would be fulfilled, and to great extent we can predict. So we have got indirect predictors, but before somebody gets an acute myocardial infarction, that can be predicted by algorithm through artificial intelligence, the highly sensitive drop eye, and the even the arrhythmias algorithm. So they will be with a variable watch, you can predict Yes.
Sir, my last two questions for you in 2022. One is about one of the budding scientists, or say you can say, he was Mr. Akash, who was working on prediction of impending heart, say, attack, say rather impending MI. He had his grandfather suffered from it, and he was awarded by the President of India at that time. So some specific protein he was working on, and he succeeded also. Any comment on that?
Yes, I think yet we are looking at something before these proteins get released. Because once they start getting released, like drop I or CPK or myoglobin, so these molecules, once the heart attack happens, then only they get released and then you diagnose it. The question is that can we diagnose it 4 or 5 hours before or 10 hours, 12 hours before? And that answer is going to come with the molecule. So you are right that he was awarded this thing, but yet, so that was few years back, but definitely we have not yet the answer, clear-cut answer in that direction. But I am sure that the way artificial intelligence is coming in medical field, that will change the whole dynamics.
So my last question is, where you place this bempedoic acid, is it add-on to the failed statins, or is it alternative to the indolence, or prior to the injectable and PCSK9, which is so costly?
Yes, as of now, we are in good position.
Has it been also combined with azithromycin?
Yeah, so that's what Dr. Tulsi was also saying, that when you combine with statin, azithromycin and bempedoic acid, you got the best reduction in LDL cholesterol and the event rates. As of now, given the evidence, with the guidelines, there also it is at best in people who are intolerant to statin or as an add-on to statin. We need to have more data. As I said, that the last week's data is very promising in that direction. Probably that will, make it an independent foray as well as the statins. But it has to go a long way to, the data has to come in favor of bempedoic acid.
Sir, Dr. S.K. Singh has a question.
Thank you, sir. So the end of the year, and for this year, from Dr. Viveka, we are hearing. My congratulations to Dr. Viveka for the whole year. We are here. Number 2, today's question for anti-lipids medicines. One is rosuvastatin, other is also important, rosuvastatin. Rosuvastatin added from medicine to become acid. But rosuvastatin not added any medicine. The question is, why rosuvastatin added this medicine? You already explained. In my feeling, the market of the rosuvastatin down. That's why they added. Otherwise, I am also taking rosuvastatin. It will have very no problem. If I will take the rosuvastatin, so many problems. Rosuvastatin says 10 mg rosuvastatin equivalent to 20 into 40 into 80. So why this compare to add this medicine formic acid for the management of the anti-lipid agents?
Sir, I think Dr. S.K. Singh want to say, why you are combining with rosuvastatin only? Why not combining with rosuvastatin?
Yeah, I think very soon we will have atorvastatin also, but the rosuvastatin is much more robust molecule and it will decrease, but obviously there are people who will have myotherapy and other side effects with that. So those who do not tolerate obviously atorvastatin can be taken, but I think in near future the other companies with atorvastatin and all would also combine this molecule.
Sir, my last question. Are there any India-specific studies on this combination or on this molecule?
So not yet, but they are in pipeline. I think they are close with this combination probably will have.
I think friends, we must give a big hand to Dr. Viveka Kumar. And permit him to leave. He has to go. I would request Dr. JPS Tulsi sir
to take the CME forward, introduce our honorable speaker, Dr. Monashis Sahu, for the second talk.
Thank you, Dr. Viveka. So, friends, we have another stalwart, Dr. Monashis Sahu. So when I asked him to pen down a few words, he indeed penned down very few words regarding his biodata. Such a modest endocrinologist. And all he said was that I am Dr. Monashis Sahu and I have done my DM endocrinology, and he is a fellow of the American College of Endocrinology, and he has his center, Dr. Sahu's Hormone Center at GK1. He is also attached to Max Punchil. And he is going to talk today on the latest updates, triple drug therapy in diabetes management. Dr. Sahu, please.
Thank you so much.
Sir, volume.
Please.
I hope I'm audible enough. Alright, so since it's already 10:05, so I'll try to limit this presentation. If not for anything, but for the solitary reason that this is 28th of December, so let's have some time for cheers together.
Wow.
The only purpose that, if at all, I can solve today is, since the topic is about a triple drug therapy, is just to answer about 4 fundamental questions. A, why to use it? B, how to use it, which of course, this is also a fundamentally very important question. Before food, after food, these are key important questions. The third is when to use it. And then the fourth important, the most pivotal question is when not to use it. I do understand it's a kind of it's not only a diabetes specialist related interaction. I do also equally acknowledge that this is a multi-speciality interaction as well. So one of the very important things, like as an example for the previous talk, I was not aware so much about the bempedoic. I must thank the forum as well to teach me out. So I hope that I can do the same for this combination of triple drug, which is sitagliptin, dapagliflozin, and a metformin. Now, when we talk about the triple drug therapy, the only competitor in that landscape is another triple drug therapy, which we do understand this is a classical glyceride, the metformin and the voglukose, which has never appealed me from a scientific rational perspective.
Sorry to interrupt, Dr. Sahu. Can we have some silence at the back, please?
Of course. That's okay. I mean, I'm okay with that. So,
Dr. Jaspreet, would you like to come and sit?
Yes.
Oh, quite.
Dr. Ashish?
Quite.
Please sit, sir. Thank you. Good, sir.
Okay, since this is a popular demand because ultimately the ultimate goal is to be at that place, not to listen here. Nevertheless, so I'll just quickly roll on as to the only reason as to why we need to keep on talking about some combination agent in an FDC format is only to improve upon the compliance. And as a practicing diabetologist, all that I can assure is that every compliance that we are ensuring for our patient always has an intent of improving upon the HbA1c. Now, it's like a slide which is like a mirror. Despite all the advances of the scientific advances, seminars, webinars, if a fundamental question comes is that even across specialty or across the test of the center, what is the average HbA1c that is attained? So, coming from 2014 to from Dr. Shashank's data point, which was related to the STAR study, where the average of an HbA1c attained was still around 8.2%. Till around 8 years ahead, 2022, this is an ICMR data across multiple sites which has been actually taken in. Ranjita Mohan was author out here in 2022. And north, south, everything combined. The average HbA1c which was still attaining for most outpatients is 8.2%. Now this therefore brings a very important aspect is that What is the fundamental goal of so much of scientific advances, seminars and webinars, etc.? We need to acknowledge at least a very simple concept that the reason and the fundamental goal for treating diabetes is not just to prevent a macrovascular event, it's also to prevent a debilitating microvascular event. We're talking about the debilitating neuropathy, we're talking about retinopathy, we're talking about nephropathy. So even while we stand today in this era of what agents can reduce the cardiovascular event, that does not take away the solitary important goal of an absolute control of an HbA1c, which has stood the test of time, that this is equated to your complication events, be it microvascular, etc. MCQ question, where did this fasting blood glucose of 126 had come, or an HbA1c of 6.5% which had come? What is that end point based on which this data set was given? I said, why do we say that diabetes is fasting more than 126? The reason is that there was an inflection point beyond which that the moment it is more than 6.5%, that is where the retinopathy complications start. So the role of these data set of talking about HbA1c, fasting plasma glucose, is all to do with the microvascular complications. That does not even take away the importance of macrovascular complications. Now, why are we talking about the fixed dose combination? The three drugs combined into one. I sometimes to my patients, and that's what I learned from my diabetes educators, that if you have ever taken that Ayurvedic medication, it has got a concoction of so many other ingredients. So when we talk about a fixed dose combination, that also has those ingredients with a different mechanism of action. And when we talk about the ominous octane from a pancreas to the kidneys to the muscles, the neurotransmitter is the most challenging one to talk about, and which are the agents which can really impact upon it. Is it bromocriptine? Are these agents like the GLP-1 receptor? It's still something like an evolving space of science. But overall, the entire octet needs to be controlled, needs to be impacted upon if we are talking about the mechanism of action. So the question of why an FDC, we need to choose an FDC which has got a three different mechanism of action to impact upon the overall diabetes control. So why again are we talking about FDC? Of course, we do talk about this high trail burn, so that's without any doubt. But nevertheless, the uniqueness of such kind of an FDC is also to talk about which are the FDCs which can impact upon the weight gain, which is a pivotal disturbing factor in the management of diabetes, and do they have a kind of a multiple mechanism of action to impact upon it. So that's where this combination which is now coming with an SGLT2 inhibitor, the DPP4 inhibitors and the metformin, I believe that it will see its own place and gradually. Now, when I was talking about the fixed dose combination, the triple, the only competition in terms of the triple fixed dose combination is with like the glimepiride, the metformin and the volvivos, as I was talking. It has never appealed me scientifically because there's one agent which needs to be given before the food, there's the second agent which needs to be combined and has to be given with the food, and then there's a third agent which needs to be better gastric tolerability after the food. So for me, it's like, okay, it's there for the patient, but the scientific aspect was never appealing to most of the people. When we talk about this FDC, be it the dapagliflozin and acetagliptin and the metformin, the question would automatically stem out. Are there any specific data point? Like, as an example, the combination of Bempedoic and Rosuvastatin is still being evolved. So I need to ask the question, is there any data point of acetagliptin, dapagliflozin, metformin? So that's what I was going through. But the pivotal and the vital component is, when we write a therapy, we need to think about that, what is the vital component? Now metformin, of course, we're talking about the anti-aging aspects of metformin before the conference. Metformin is standard. But when we talk about dapagliflozin and sitagliptin, I'm taking the liberty of the word just to talk about, I believe that there is an agent which is really saving something. And that's gliflozin for us. That's gliflozin for the patient. And the safety aspect, it's now standing to the test of time. We see that it's safe from a cardiovascular perspective. It's saving the kidney. It's really retarding the decline of an eGFR till the person is landing into an end-stage renal disease. So that's the safety aspect. And when I talk about an agent which can truly take care also about the postprandial hyperglycemia, which is the special unique aspect for most Indians with their high carbohydrate load, that's where we need to net that goal, and that's why I talked about that sitagliptin, etc., or any kind of a gliptin. So we need something as a savior for a goal, and we also need something which can really put that goal into the net. You can hate those two characters out there from the World Cup, but I think both of them are needed for winning the World Cup. Now, we do understand from a dapagliflozin, just looking over the slides, there is a good HbA1c reduction. B, there is a weight reduction, so there's so much of pleiotropic effect. C, when we asked about what exactly is the fat reduction, is that a fat reduction, is it also a lean muscle mass reduction? So this was an interesting data point where they went up to around 102 weeks. It was a subset where they took a very defined, not a very high HbA1c, but a lower set of HbA1c, and gave a dapagliflozin to as long as 102 weeks to find out one important question, that does it have a negative impact on the bone remodeling? The answer was none. But through that data set, they also looked around the DEXA modeling, and what is important to acknowledge the fact is that the total fat mass was essentially impacted with dapagliflozin over the period of 102 weeks, and not so much of an impact on the lean body mass. Also on the blood pressure, a very important aspect out here is that despite on pioglitazone or an insulin, so there was also a blood pressure reduction. Despite an agent which can lead to a fluid accumulation, still of those subsets, there was BP reduction. And without a hypoglycemia, as we see, all of us are aware about it. This also comes with an added advantage of dapagliflozin, where it has been studied with that no added cardiovascular event, and there was a reduction of hospitalization to heart failure, reduction with all-cause mortality, which has been seen in a heart failure subset of patients, not otherwise. And the most important out here is that it's not just only in the setting of diabetes, it's also in non-diabetic patients who can be given a dapagliflozin, as it was seen with the DAPA-HF study. And the DAPA-HF study also led to another important interesting observation, that individuals who never had diabetes with a heart failure, when given dapagliflozin, led to a reduction of incidence of diabetes. So that's also an important aspect of dapagliflozin. Through a lot of readings which have come to a conclusion, it's not only a unique mechanism of dapagliflozin, as all of us are aware. I see no difference as to a similar effect of empagliflozin or canagliflozin as well. The next important, and this is again the data set which has led to dapagliflozin, which can be used to an eGFR of 25, and the reason is why, because in DAPA-CKD study, interestingly the makers, they studied in the chronic kidney disease, even if it was a diabetes or a non-diabetic, and being given dapagliflozin for a long duration, and they tried it with an eGFR even as low as 25. Now just based on this inclusion criteria, and based on the finding that the primary outcome, that is the retarding of further progression of renal disorder, and this p-value has got the most substantial p-value which has ever come across, the 7 zeros out here. So that has led to the recommendation that dapagliflozin can be used up to an eGFR of 25. The earlier recommendation was an eGFR of 45. Now that would lead on to a very important question of when not to use it, and reserve that statement towards the end of this topic. So overall, dapagliflozin as a solitary entity can be used to an eGFR up to 25. Earlier recommendation was up to an eGFR of 45. Now, so that's saving both from the kidney as well as the cardiovascular landscape. For sitagliptin, I'd just like to draw your attention, all of us have been using it, that even when we talk about a postprandial hyperglycemia, the substantial reduction of almost like minus 81 milligram per TL, especially the Japanese subset, is of no surprise. And as we are realizing, our DPP-4 enzymatic activity is actually at a higher pedestal. So therefore, DPP-4 inhibitors have got a more substantial reduction of an HbA1c among Asians as compared to our Western counterparts. So somewhere out there I see, and that's why I said that DPP-4 inhibitor probably has got an ability to just push that HbA1c into the goal, and that's why we have that messy factor to the DPP-4 inhibitor. The sitagliptin per se has also been studied as a part of a TCOS. Well, that does not really help us substantiate that now please we need to have some data. Like, are there any data for these three agents? So that's the fundamental next few slides. Is there a data for a sitagliptin and a dapagliflozin and a metformin? We are not talking anymore about SGLT2 or a DPP-4 and a metformin. So while with the rationale, and I'm just skipping the slides, I think we have enough of rationality to use it, different mechanism of action. The moment HbA1c is more than 1.8% beyond what is desirable, I would rather use this triple dose combination among the patients. So what's the clinical evidence? Well, the clinical evidence was way back in 2014 itself, when the specific agent of sitagliptin with a dapagliflozin, with the metformin, so I'm using the specific molecule aspects, that has been studied over a period of 24 to 48 weeks. and what was found was no surprises. There was an HbA1c reduction of close to minus 0.8%, and that's in the baseline of HbA1c reduction more than 8%. Now, also most of them, the safety results, except for the genital tract infection, which was higher in this FDC. I must also state that while dapagliflozin per se has got a GTI as adverse event, but it has been amply studied and has been amply seen that when it is given in a fixed dose combination with the DPP-4 inhibitor, the GTI essentially reduces. Now, so that's about the Western data, long back in 2014, not as a part of FDC, but it was like different drug products that were used. Is there a data subset for an FDC? So that's the thanking the medical division of Sun Pharma. They have the data, and they essentially ran a trial. It was a beautifully organized trial. Well, the conflict of interest being that we are advised to them. The fact is that they took in terms of the overall, when patients had failed on metformin, they were on a stable dose of 1500 milligram, and they were divided into 3 arms. The FDC arm, the one that is a sitagliptin, dapagliflozin, and metformin. The second person. Now, what it should lead to our art of practice is that wherever the HbA1c is at least more than 1.5%, beyond what you want to desire for the patient. So as an example, for a 30-year gentleman, I'd like an HbA1c of 6.5%. Maybe for a 65 years old, I'm okay with an HbA1c of 7%. So whatever be a kind of a delta change, if it is more than minus 1.5, would rather use a triple dose combination for the benefit of the patient. There was a substantial reduction of again the postprandial glucose, which was minus 50 milligram per dl, with the weight changes as well. The question here is, although it's a small subset, but enough to help us understand that is there safety data? The answer is that yes, there was a safety data. Overall, as we see, the overall any treatment emergent adverse event was around 10.2%, which was slightly more. And we do expect that because that's a comparison with the genital tract infection. But it did not lead to any kind of a dropout. So that's a very important satisfying factor. So overall conclusion being the FDC has been studied, and it was studied in comparison with sitagliptin metformin if being given, and it was studied in comparison with dapagliflozin plus metformin if given. The HbA1c reduction was minus 1.7 over a period of 16 weeks, and no major safety related aspects. So where to use it? And this is just a kind of a case study, 5 years of duration of diabetes with metformin 2 grams per day, and it's a reasonable situation where the fasting blood glucose as you see it is 137, not so bad, with an HbA1c of 8.9%. At 51 years, I would typically want an HbA1c around 7%. A simple mathematics with a delta change of 1.9% if you're desiring for this patient will not happen with just an addition of any agent like the sitagliptin, etc. And these are especially those issues where one can use an FDC, if not for anything but for the benefit of weight loss and a reduction of the waist circumference, reduction of BMI, etc. So that's where the bias is, not for a dual combination. For metformin, if you go for let's say sitagliptin and metformin, that is not going to take care of an HbA1c. And a very intuitive factor that since we have to take care of the inertia both for us as well as the patient, the triple dose combination is a boon for such kind of an individual. Is there a guideline? Well, there was always been a guideline, and even from an AAC concept, once the HbA1c was more than 7.5%, it always talked about dual therapy and triple therapy. So finally, that's this penultimate slide. We say that treatment of type 2 diabetes mellitus is complicated. The fact is that once we understand what agent can reduce the HbA1c, does it have a hypoglycemic potential, does it have a weight gaining potential or weight lowering potential, I think it's fairly simple now. Let the specialist not complicate the management of diabetes. So I think it's fairly simple nowadays. And we just need to apply a little bit of a commonsensical mind. So I'll give my example of one of the patients who just attended the OPD today. Why sometimes in the quest of all this modern advances, we should not forget the old agents as well. A cancer survivor who needed an agent which essentially works around a pathway of a PI3. And that is the pathway where we really need to reduce the insulin levels for the overall survival for the patient. All these old agents have to be out. All these newer agents sometimes which can really improve upon the insulin levels has to be out. The older agents such as pioglitazone is still a boon for such kind of a patient. So we really need to understand what insulin sensitivity we are using as well. Similarly, the AGIs, it's so less talked about, so less used, but fundamentally for most of our patients, it's so helpful. But nevertheless, the FDC out here, the fixed dose combination, it just helps on the compliance part of it. So it's something like if you use a sitagliptin, dapagliflozin and a metformin just once in a day, it just gives that 1000 milligram of metformin per day as well. All three has got different mechanism of action, and different HbA1c is more than 1.5% beyond the baseline as to what you want to achieve. That's why the FDC is really needed. So finally is that it's always a teamwork. Have a savior which can save the organs. Have something which is a potent agent as well, which can really put that ball into the net of an HbA1c. And on the background of the wonderful metformin. Thank you so much for taking the question.
Sahu, would you like to join in here?
Gallery. Like,
So friends, what a fantastic talk we have had. Manish says yes. So, Dr. Sahu, the most global cardiology guidelines today recommend early use of cardiovascular and renal benefits drugs that not only are glucocentric, probably have some benefits, cardiovascular benefits, renal benefits, and as we know, diabetics have augmented ASCVD. Dr. P said yes. So, of course, DP4 inhibitors, are they all similar, Dr. Sahu? JAMA cardiology, Dr. Chandrasekhar says yes. Published the TCOS trials, Dr. Sushil says yes. And said that amongst the gliptins, Sita seems to have the most favorable CV outcomes. What do you say, sir?
Well, I would just take it as a kind of a safety gliptin as well as because gliptin also has improved studies in a very advanced, very high risk cardiovascular population. Because 1 crore of patients also had a kind of a decline of an EG.
Right.
Mike. Volume, sir.
I'm whatever.
Yes, so the mic can also so overall in terms of sitagliptin and the linagliptin, I would equate them in one similar bucket and the saxagliptin on a different bucket. And in terms of which is the most cardiovascular safe, I would still rate that I can have kind of a handling. So the sitagliptin and the linagliptin, it's all in the one bucket. And the saxagliptin is a different bucket. So there's no such thing that I would be the most cardiovascular safe. The sita and lina is okay, but even the saxagliptin, unless until they are talking about hospitalization of heart failure, otherwise negating that aspect, it was had a reasonable data as well as compared to.
So, Dr. Sahu, we have a pulmonologist friend, Dr. Mangala, sitting with us. And Dr. Mangala, so they said Sita probably reduced, death in COVID by a whopping 77% as compared to insulin, and also reduced ICU admissions and mechanical ventilation as well because of effects on ADA, that is the adenosine deaminase activity. What do you say, Dr. Mangala?
I think it's all fraud. All fraud.
Very rightly said.
One word is all fraud.
Yeah.
Just statements.
Just a statement.
Mainly metformin is recommended.
I manage all my patients on insulin and linagliptin.
Right. So linagliptin is also a DPP4 inhibitor.
Yeah.
So do you say that
I just manage the diabetes part of.
So do they have some effects?
You can't say.
No.
You certainly can't say that these drugs only matter. It was a different illness.
So Dr. Mangala says it really doesn't matter, but he managed his patients on linagliptin and metformin and insulin as well. And the verified study, Dr. Sahu, talked about metformin. See, with DP4 inhibitors gives protection to beta cell apoptosis. So, is there some, benefits when you combine DP4 inhibitors and metformin?
Yeah, so that's it. From a geoprocessing perspective, one of the fundamental aspects is beta cell preservation, and there have been many animal models as well with gliptins and preservation. And that's the only reason as to why initially when gliptins had come as a part of therapy, the word durability of a diabetes control was the first kind of a scientific term which had come and got associated with gliptins. Mechanistically, it is associated with the beta cell preservation. So, and in terms of the biounits, in the combination of biounit, see, metformin has got a very potent also an anti-inflammatory role. And that's where there's been so much of purported hypothesis. I think this agent is almost everywhere, the metformin. And so the combination of gliptin plus a metformin is mechanistically is an excellent choice, even for a beta cell preservation. We also talked about a verified trial. So verified trial, what did it tell us? They included patients who did not have a very high HbA1c. It was a very HbA1c which is closer to the target. All they asked, formulated a hypothesis that, okay, we have been doing this metformin, if metformin fails, and go on to gliptin. So they simply went on to kind of, okay, why do this stepwise approach, better we give a gliptin plus metformin. And they found that over a period of those entire duration of the trial, went on to 5 years. The chances of failure with usually hitting it very hard and early, the chances of having a failure was markedly less in that group of gliptin and the metformin. And most importantly, there was no hypoglycemia. So all these should lead on to kind of a practice-changing attitude is that we don't have to go for a stepwise approach. So even HbA1c, if I can just take from question to other question, an HbA1c which is let's say around 7.8%, you want to drop it down to around even 7%, use a DPP-4 inhibitor and metformin rather than just using a metformin. On a similar note, with due justice to this topic of a triple dose combination, if an HbA1c is around 8.9%, straight away one can go for a kind of a fixed dose combination or triple dose combination.
So our communist friend gave his impressions regarding DP4 inhibitors and COVID. I'd like to have your impressions, DP4 inhibitors with COVID.
So the first and the fundamental goal is to control the diabetes by hook or by crook, because it has, it's a hyperglycemia which is the most important factor.
Will they reduce ICU admissions, sir?
No. We don't have a data.
The final word is they do not reduce
No, but
ICU.
I'd like to just add on to something.
Okay.
Long back, there has been a mechanistic study with vildagliptin related to COVID virus replication, and somehow that has been shared. We don't have data, but overall, is one of the great choice in the setting of a COVID of a DPP-4 inhibitor if you want to compare with HGL.
So friends, that's settled. So the DP4 inhibitors have no role to play in COVID. So Dr. Sahu, talking about some groundbreaking treatment, newer treatment options, both for type 1, Dr. Chauhan, and type 2 diabetes, newer groundbreaking treatments. Type 1 is shield, so probably ZIL. I'm talking about the cephalosporin injection to significantly delay the onset of stage 3 type 1 diabetes. Your impressions on that? There are two, one for type 1, one for type 2. What, sir?
Well,
US FDA approved.
Yes. The data, I still feel it's not very robust and strong enough. But having said that, any monoclonal antibodies, it is being tried, tested, and time and again. I'm telling this because I've been into part of drug development. There will always be a quest for some kind of monoclonal antibody from a type 1 diabetes to reduce autoimmune destruction. That's one. As a whole, type 2, I'm still not aware of it.
When you say that the data is not sufficient, I would probably swallow it with a pinch of salt. US FDA has approved this drug, and it says that this is a disease-modifying drug. 2 years, delay by 2 years. That's enough for patients to. This is a game-changing medicine. And then for type 2 diabetes mellitus, Monjaro. See, a GLP-1 and a GIP agonist, greater HbA1c reductions, what is it? And greater weight loss. 90% of people could achieve HbA1c of less than 7. What more do you desire? Dr. Sahu, talk us through that. Again, US FDA approved, sir.
Yeah, For that note, even a bromocriptine will also be approved for categories. The fact is, when we talk about Monjaro, we need to understand it's still not come here to India. It is the therapy which you would have seen Elon Musk also speaking about it, about many other Viveka as well. The GLP and the GHD combined together obviously makes a very intuitive choice for A, the weight control, and B, diabetes control as well. So is it a great therapy? Everything is a therapy, everything has got a kind of a choice in terms of controlling diabetes, and the most best advantage is related to the weight control. How do I see it happening among India? Let it come first and let's have that choice and choice of therapy. So most of the therapies that we're talking about is of course a US FDA approved. I cannot really comment about as to what significant benefit will it bring to our population.
So what was significant, friends, was 15% dropout in Monjaro as compared to 26% dropout on placebo. What more can you desire, Dr. Chauhan?